that's a question that we get all the time is, and I'm going to talk about hope and giving up hope here in a minute. So it's that 6-month prognosis, and if you choose to go seek aggressive treatment for your terminal diagnosis, then you just come off of hospice. The other thing that is a misconception I think about hospice is that we look at your terminal diagnosis and your terminal prognosis. And so if you come onto hospice for lung cancer, but you have a diabetic foot ulcer, you can still go into the hospital for that diabetic foot ulcer. You can still go see your podiatrist or your orthopedic surgeon. You can still get very aggressive treatment for that diabetic foot ulcer because it is not related to your terminal prognosis. That diabetic foot ulcer in and of itself is usually not a lethal terminal condition. That's not to say that other factors in that infection may overwhelm your body, but just the diabetic foot ulcer, people live with diabetic foot ulcers sometimes for years. They get treatment. You can cure a diabetic foot ulcer, and so that would not be related to your terminal diagnosis. So when we come into the picture for your lung cancer, we're going to tell you your diabetic foot ulcer is not related to hospice, so whatever treatment you're getting, whatever physicians you're seeing, if you need to be hospitalized, that is still an appropriate measure for you to do. And that's where we come in. And if you don't know for your loved one, if you don't know for yourself, if you don't know for whoever it is that you're helping navigate these waters about whether or not hospice is appropriate or not, that's where we come in, and we do referrals. And so Michelle's one of our community liaisons, and she'll go out and she can sit and talk about hospice for hours. And so if you're bored on a Wednesday afternoon, call Michelle. She'll come talk with you.
I will.
If we need a more clinical evaluation, then we can reach out to one of our nurses or to our nurse practitioner or to our social worker, someone that has a bit more clinical education than what Michelle does. And Michelle's great and she knows a lot, but if it comes to some of the specifics about diagnosis and disease, then she needs to hand that off to one of our clinical folks. And we've got 3 admit nurses within Hospice of Lubbock that can come out and make that referral visit and look at the clinical picture and then help you or your loved one or whoever it is that you're advocating for make a decision when it comes to hospice. So I believe it's never too early to call hospice. I think you can always call hospice, you can always get an opinion, you can always ask someone who does this day in and day out what their thoughts are regarding hospice. And we'll tell you, if it's too early, we're going to say, you know what, it's too early. That Alzheimer's patient that's still driving, that still can handle a shopping trip to the grocery store and still shop for themselves, that's not a hospice appropriate Alzheimer's patient. And so we'll tell you that. And we may follow up with you in 6 weeks or 6 months, or you may call us in 6 days and say there's been a dramatic change in this person's condition and I would like for you to come back out and reevaluate them. And that's always appropriate. Another example about that, not to belabor this too much, but strokes. We're seeing a lot of patients with strokes right now. And in the short term of a stroke, you may or may not know how that patient is going to do. And so patient may have said, I don't want a feeding tube. A patient may have said, I don't want to be kept alive on a ventilator. And those are all fine directives to give to your physician and to your family. And if they choose not to intervene in those methods, then hospice may be appropriate because they've forgotten how to swallow. That stroke has taken out their ability to swallow. That stroke has taken out their ability to turn themselves into bed, to toilet themselves. And they may have chosen that that's not how they want to live. But then you fast forward 6 weeks and the brain has started to figure it out. The brain has started to bypass some of those normal mechanisms or to pull in other processes in the body, and now all of a sudden they are swallowing, and so they are able to take in a few calories on their own. They have figured out how to maneuver the leg that wasn't working, and so now they're moving a little bit more, and it may be appropriate to come off of hospice. And our hospice will tell you that as we see that. So a couple of times in the last 10 years, I have said to a patient who's had a stroke, you know what, you're getting better, and you're getting better enough that I think with some therapy, you could live a productive life, you could live a life that you agreed to, that is a quality of life, and hospice may not be the appropriate place for you today. So there's always this ongoing evaluation of hospice services. So that's what hospice is. Hospice is a terminal diagnosis. It is a prognosis of 6 months or less. Pancreatic cancer, about 95% of a pancreatic cancer diagnosis is going to be terminal. but it's where does that prognosis of 6 months or less come into play. And so we'll help you look at that. So if you ever have questions about a hospice diagnosis, a patient who's appropriate for hospice, please call us. We'll be more than happy to sit down and talk with you about that. Yes, ma'am.
A question. I know that, the treatment of a terminal diagnosis isn't something you do in hospice, but if the treatment is palliative for that terminal diagnosis, is that something that someone would stay on hospice for, or would they switch over to palliative for that?
Yeah, so that's something the hospice would be responsible for. And so we are responsible for any symptom management that relates to that terminal diagnosis or prognosis. So pain and nausea, vomiting, shortness of breath are some of the easiest that most patients with a terminal diagnosis are going to have. And so we're going to use medicines to help control those symptoms. What gets a little bit more gray, maybe, is the cancer diagnosis, the prostate cancer that's got disease in their bones. And so palliative radiation is something that we would do as a hospice because that is a symptom management. So you're treating pain using radiation therapy to do that. Now, we might not draw that out for 6 weeks or 8 weeks or 2 months like the radiation oncologists normally do. We might target the one area of the spine or the pelvis that has a huge lesion that is causing the majority of the pain. Maybe we target a scapula or a collarbone or a rib. And so we might do targeted therapy, a higher dose radiation therapy 1 time or 2 times, and treat that pain. But yes, so anything that relates to the symptom management of that diagnosis is ours to be responsible for.
Are you an inpatient, or do you also go into the homes of folks?
Right, so
on
we're
hospice?
primarily community based. So Lubbock does not have an inpatient hospice facility. So if you've been in larger cities, you have inpatient hospices that people can go to for symptom management. Sometimes they can go and pay room and board and actually live there because it's an inpatient hospice unit under their hospice diagnosis. Lubbock doesn't have that. So we are out in the community. We are in assisted livings, we are in nursing homes, we're in patient homes. We've even taken care of some homeless patients, and we follow them from house to house or from open door to wherever it is that they may be. And so now if we need to bring them into the hospital to manage their symptoms because they need that nursing intervention, they need that IV pain medicine that we need to get started in the hospital, then we bring them into the hospital, whether it's UMC or Covenant. Those are our 2 facilities that we contract with to provide those inpatient services. That's meant to be short-term and then to return the patient to their home. That's a great question. Thanks for asking.
So my mother-in-law, my wife's mother, is 92, has severe dementia. She would be one of those people that could walk here to that table. She would need to stop on the way and rest. She had to walk. Do you provide respite services, like for a week or a couple of weeks, or caregiver? My wife is a caregiver, to get away for a while.
Yeah, so the Medicare benefit, and again, I come back to that because that's really how we define those things. Medicare says that you get 5 days of respite. And it's a pretty poorly defined benefit, if you will, but it is one of the things that we offer. But 5 days means if you go into respite, and respite from our standpoint has to be provided in a Medicare-approved facility. So it has to be a nursing home. It has to be a Medicare. It can't just be your brother's house, or it can't just be if you know Sally that she takes care of people because that's what she has a heart for doing. It has to be a nursing home that's Medicare licensed or a hospital that's Medicare licensed. So it's a 5-day benefit. You go in for respite on a Monday, you have to come out on Friday, according to the Medicare benefit. Now, if you needed 7 days and we put your mother-in-law into a nursing home, hospice would pay for the first 5 days and you could pay for the other 2 days, but Medicare doesn't allow us to pay for more than 5 days of respite. So that might be that you need to attend a funeral out of town. It might be that somebody's getting married in Dallas and you need to get away for a weekend. It may just be that your wife says, I need to sleep for 3 days and I really could use a break. So then yes, that benefit is available. So you come out of respite on that 5th day, you come back home. And then let's say 4 days later, so you went out of town for 5 days. That was respite. And let's say 4 days later, your wife has to have an emergency surgery for an appendix or a gallbladder that's gone bad. We could put your mother-in-law back into respite for 5 days. So it's poorly defined. We just have to be careful. If it's because your wife and you have gotten to a point that you physically can't take care of your mother-in-law, then our social workers would be working with you to say, you really need to place your mom in a facility that can provide for her care 24 hours a day. So Medicare doesn't let you do 5 days of respite, home for a day, 5 days of respite, home for a day. Medicare's gonna say, this is a room and board situation, and Medicare doesn't provide room and board. So then our social workers would be working with a family to say, what kind of living arrangements do we need to make? And there's a gamut, and we're gonna talk about community here in just a minute, because that's where hospice, being a community-based healthcare service, really relies on our community partners to help us care for our patients. So maybe that's a great segue into, so the title of this talk was Creating a Community of Dignity and Hope, right? And all good sermons have 3 points, right? Is that what I learned? But when I thought about that, when I thought about the 3 words in that title, community, dignity, and hope, I thought that is an absolute perfect outline for what I would want to say to you all this morning. And so let's start with community. Hospice is a community-based organization. We serve 19 counties. So we serve Lubbock and 18 surrounding counties. We go to Seminole, we go to Farwell, we go Plainview,
Rawls,
Crosbyton, out that I'm trying to think the
Post.
circle, just past Post. So when you think about the 18 surrounding counties, we cover a wide array of communities, and we can't do it alone, right? So if we're serving a patient in Farwell, if we're serving a patient in Seminole, we're 90 miles away, 60 miles away, 90 minutes away, 65, I think Seminole's 65 miles. But by the time you stop in every little community, every 15 or 20 minutes, it takes you a good 80 minutes to get there. So we can't do that on our own. We have to rely on our community partners to help take care of our patients. We don't provide room and board. We don't provide 24-hour bedside care. We don't have the ability to do that. We're an organization of 65 people, and we have currently 185 patients. So part of what we have to do is provide the same level of service to every 185 patients that we serve. So I can't promise that I'm going to go sit at your bedside for 24 hours, 7 days a week, because I have to do that for 185 people. And if I only have 65 people, clearly that's not something that we can do. So when you talk about equality, when you talk about justice, we have to provide the same level of care. We have to be able to offer the same level of care to every single one of our patients. So we have to rely on the community. We have to rely on nursing homes. We have to rely on assisted living facilities to help us provide that 24-hour care. Because whether it's a cancer diagnosis, whether it's an Alzheimer's diagnosis, often what I'm telling patients and families is, so I've been married almost 20 years. It'll be 20 years in January. So when Beth and I got married in 2001, and we promised to love and to cherish and to care for each other in sickness and in health, we have no idea what sickness and health looks like when we're 85 and when we're 90, right? And I would suspect that you didn't know that either, whether you're married, whether you're divorced, whether you have kids, whether you don't. You had no idea when you were 20 what 80 was going to look like. We have several patients on our service that are over 100 years of age. They had no idea when they were 20 what 100 was going to look like. I mean, a patient that was born in 1920 had no idea what 2020 was going to look like. I mean, think about that. 1920. I mean, we barely had the Model T, we barely had an airplane, and now we've got a computer and a cell phone, and we can take our entire life with us in a device that fits in our pocket. So we have to rely on the community, because when you made that promise to love and to honor and cherish when you were 20, you had no idea what 87, what 90, what 100 looked like. The reason that we have kids, hopefully when we're 20 and 30 and not 70, is because kids are hard, and kids take a lot of time, and kids take 24-hour care. Our loved ones, when you get to a 92-year-old with Alzheimer's, likely requires 24-hour care. They sleep at noon and they're awake at midnight, and that's the antithesis of the way the world works. So if we don't have our community partners, we're not going to be able to provide care because we can't physically be at the bedside 24 hours a day. Now, what I think hospice does better than any other organization in the country, really, when it comes to healthcare, is that we're available 24 hours a day. So when you need us at 2 o'clock in the morning, we're a phone call away. Nothing ever happens at 2 o'clock in the afternoon on a Wednesday. It's always 2 a.m. on a holiday weekend, 99% of the time. So when your loved one is in crisis at 2 a.m., you call hospice and you say, Mom's hurting, my wife is hurting, this pain crisis has come on in the last 2 hours, what do we do? And you've got a nurse that's going to say, take an extra dose of your medicine, let me call the doctor. You've got a doctor on the other end of the phone at 2 a.m. that's going to say, okay, let's give an extra dose, let's give a dose every hour, let's call them back in an hour or 2 hours, and if that's not working, then let's get them admitted to the hospital, or let's try a different pain medicine. You've got 24-hour pharmacies. So right now, if you have a cough and runny nose, and you've got a call, you wake up at 2 o'clock in the morning and you can't breathe, you've got two choices. You either wait until your doctor opens at 8 o'clock and say, can I please get in? And they're like, sure, come at 4 this afternoon, right? Or you go to the emergency room, and in the midst of a global pandemic, you sit in the ER for 18 or 24 or 36 hours, maybe before you're even seen by a physician, all right? So the beauty of hospice is that if you are on hospice and you call me at 2 o'clock in the morning, you say, I'm short of breath, I think I've got a pneumonia, all these things are going on. We've got a couple of options. We can send an x-ray tech to your home at 2 o'clock in the morning and get an x-ray and have results by 8 or 9 o'clock that morning. We can call a 24-hour pharmacy and get you an antibiotic. It's like, you know what, you've got lung cancer, you're coughing up sputum that's gross and ugly, you've got a fever, and you probably do have pneumonia. Let me just get an antibiotic from Walgreens and I'll have it to your house by 5 or 6 o'clock in the morning. You've taken your first dose of medicine, you've never gotten out of bed before your doctor's office ever opened at 8 a.m. That's the beauty of hospice. When hospice works the way that it's supposed to. Now, unfortunately, if you live in Farwell and it's just snowed and there's 3 inches of ice on the road, my nurse is not going to be able to get to you at 2 o'clock in the morning. We're still going to be able to tell you to take an extra dose of your medicine. We're still going to tell you to increase your oxygen. We're going to tell you that we're going to get there as soon as we can. If you've got a local pharmacy that opens at 8 a.m. and they'll deliver to you, we'll call it into your local pharmacy and they can have you meds by 8 a.m. You still didn't have to get out of your bed. You didn't have to get dressed. You didn't have to sit in a COVID overrun emergency room for 24 hours, and you've gotten the care that you needed within hours. So that to me is always the benefit of hospice, and that's why if you're on the fence about whether or not maybe you want more treatment, maybe you don't, but maybe you want hospice, this is the reason that you go in hospice, because I think you can get better care quicker in a lot of circumstances. It means that we're not going to cure your disease. It means that you've gotten to a point that there is not a cure, but that doesn't mean that we can't help you. That doesn't mean that we can't take care of you.
So that's probably a good place right there to ask the question that I wanted to ask was, at what point in time should I pull that trigger to call hospice and say, I think I've got a lot of symptoms and I need your help?
Whenever you ask the question, you should ask the question. If you're asking yourself, and I've told my residents, my med students, my nurses, I've told anybody that I'm responsible for from a teaching and oversight standpoint, if you think, I wonder if I should call fill in the blank, you should pick up the phone and call fill in the blank. Your doctor, your lawyer, your banker, your pastor, your hospice nurse, your physician. If you think, I wonder if I should call, you should pick up the phone and call, because that's going to put your mind at ease. And again, my job at hospice is to tell you if it's too early or not.
I was really thinking about my mother-in-law, but the second question to that then is, and I hope this is not taken the wrong way, at what time do you need, what are the symptoms that you say, boy, this person is, a month away from dying? What are the indications there?
So we have we should have brought some books. We can bring it next time. There's a book called Gone From My Sight. You can find it online. You can find it at the hospitals. We've got some at Hospice of Lubbock if you want to come grab a couple. It's written by a hospice nurse, and it breaks down kind of the changes that you see in patients when they have months to live, when they have weeks to live, when they have days to live, and when they have hours to live. Now, patients don't read textbooks, right? None of us read the textbook, but they follow a pretty generic trajectory. And so The Alzheimer's patients that's still walking and going to the grocery store, not hospice appropriate. The Alzheimer's patient that's forgotten how to walk, that's forgotten how to go to the bathroom, that's forgetting how to swallow, probably hospice appropriate. But then it becomes, what are you going to do when that next urinary tract infection comes? What are you going to do when they forget how to swallow and they get food or liquid into their lungs and have what we call an aspiration pneumonia? Are you going to want to be in the hospital on a ventilator and IV antibiotics? That's not hospice appropriate. That's not who we are, and that's not what we do. You take an Alzheimer's patient out of their normal environment and they get more agitated, they get more confused, they get more combative. If your loved one has said to you, I don't ever want a feeding tube, I don't want to be in a hospital, I'm tired of hospitals, whether it's heart failure, COPD, or cancer, I'm tired of being poked and prodded, I'm tired of being woke up at 4 in the morning for a chest x-ray. If you get to that point in your disease process that you don't want those things, that's when hospice becomes appropriate. We're still going to treat you aggressively. We're still going to treat your symptoms, your shortness of breath, your anxiety, your agitation, your pain, but we're going to understand that death is going to come for you, and when it comes, we're not going to stop you. We're not going to stop it. We're not going to stand in death's way.
Is a verbal directive as powerful as a written directive, or?
In my world, it is.
Okay.
Right? I mean, if you, and that's, and advanced directives are a whole nother topic we can get on someday. But if you tell me as a patient, if you're in the hospital and you tell me, I do not want you to do chest compressions, whether you've got that in a written document or not, I'm not going to do chest compressions on you. I'm going to sign a form. You're going to sign a form, and we're not going to do that. If you can't physically sign a form, I'm going to have a nurse witness your statement. I don't want chest compressions. Please don't do that to me. And if you give me that directive, even if your wife comes in 30 minutes later, you go unresponsive, and your wife says, I want you to do chest compressions, I'm going to say, nope, your name's Rob. I heard Rob say, I don't want chest compressions, and I'm obligated to honor his wishes. You should write it down.
Yeah.
Because it gets really messy. It gets really messy and sticky and ugly. You should write it down. And I'll give you an anecdote. I'll give you a story of a couple that I cared for. The husband had Alzheimer's disease. I spent multiple times in their home talking with him and his wife. And he succumbed to his Alzheimer's disease. And about 4 months later, she was driving home from church one morning and she had a stroke in her driveway. Her kids recognized that she either called them or they followed her. They were close behind her. I'm not quite sure. They got her to the hospital. She had a major stroke. She was losing the ability to swallow. She was becoming more unresponsive, and they were really struggling with what they should do to care for mom. They pulled out the advanced directives. Again, this is a woman that I'd sat in her home. I'd had the privilege of having multiple conversations with her. We'd never talked about her health because I was her husband's physician at that point. But they pulled out this advanced directive that said, if I have an irreversible condition such that I can't care for myself, even with the best medical care appropriate, I don't want a feeding tube, I don't want a ventilator, I do not want my life prolonged. If I have a terminal condition, so if it's irreversible, if it's terminal, I do not want these things. And she had a stroke that was irreversible. And so they made the decision based on her advanced directive. She was speaking on her own behalf on a written document, and they didn't put a feeding tube in her. She died within a week or two of the stroke. And some of the family was really pushing back, but you can do this. And they're like, yes, we can, but mom told us not to do it. And it was the most precious gift that she could have ever given, right? Because they didn't have to make that decision. So, yes.
One more question.
Yep.
One more question. Richard, I would think we have a lot of questions, or maybe illustrations that you can provide is where life is and where you are.
You know, I mean, hospice has been great for us. This is one of the things I've been thinking about as you've been talking. So I would say 2 or 3 years before my wife went on hospice, I'd been taking her out in the evening for a drive, and it would be 6 or 7 o'clock. She'd say, "What is it about this time of night?" And she became more anxious and disoriented. And I've studied a little bit on the sundown syndrome, but I've also been told that patients that have that don't know they have it. And so what is it in her that is similar? I mean, is there a similar syndrome that is not exactly the sundown syndrome but manifests itself in the same way?
Yeah. So I had a professor in my training explain really life like this. and I've used it, and it's really a beautiful illustration. If this is the bare minimum threshold that it takes for us to function, to get out of bed, to walk, to talk, to eat, to sleep, to breathe, right? You have to have so much gas in the tank, if you will, to provide the basic functions of life. When we're 20, we're way up here. You can party all night and go to class the next day, right? You've got lots of reserves. You can survive on 2 hours of sleep. I mean, I've pulled all-nighters in college. You've pulled all-nighters in your life, whatever it is, and you can still kind of function the next day. I was in residency. I started residency in 2005, and our MICU call was every third night. I was up for 30 hours every third night. You ask me to do that now, and I'm going to quit, because I'm a 43-year-old. I'm not a 23-year-old, and it just doesn't work that way anymore. So when we're 20, our gas tank is really, really full. As we get older, as we get more chronically ill, we're still above normal, right? This is what normal looks like for all of us. But now we're hovering above normal. So any insult to normal puts us below this threshold. And when you drop below that minimum threshold, that's when you end up in the ICU intubated because of pneumonia or because of West Nile or because of COVID, right? The 20-year-olds are out there partying and they've got COVID and they're still partying. Unfortunately, it's our 65 and older population that when they get COVID, it's disastrous because they don't have the reserves. They look normal, they're still walking and talking and functioning, but now any insult to that normal puts them below this threshold. And when you get too low below the threshold, that's when death comes. So Alzheimer's, COPD, right? You sleep all night and you kind of build up your tank reserves. As the day goes on, as you struggle to breathe, as you struggle to think, as you don't eat that well, you start getting closer and closer to this threshold. And maybe by 4 or 5 in the afternoon, you've dropped just below it. And so the dominoes start to fall because you just don't have the glue to hold it. It's this reserve that is your glue that holds it all together. That's the best, and it doesn't matter if it's cancer, if it's Alzheimer's, it doesn't matter. That's, as you get there, that's the glue that starts to come apart.
And your definition of an all-nighter in mine at age 71 is a little bit different than mine.
Perhaps.
My definition of an all-nighter these days is to go to bed and not have to get up all night long to go to bed. I had an all-nighter. Well, thank you very much for coming. I know that